May I request Dr. Unu to invite our next speaker, Dr. Unur?
Yes,
Yeah.
our next talk is from Shritar. Am I right? Adventures of endoscope assisted disc surgery or contact lumbar disc surgery. Doctor, are you ready? Shritar?
I think Dr. Sridhar is not there.
So we're passing it. Is Kulkarni here?
Yes, he was there.
Yeah. Our next speaker is Kulkarni from England. Lumbar endoscopic discectomy. Doctor, we're hearing you.
Dr. Yaman moderating the session. I thank Dr. P.S. Ramani, Dr. Professor Sahu for organizing this meeting, and good morning to everybody. Thanks for sharing our experience from King's College Hospital. Um, this is a talk on endoscopic, lumbar endoscopic discectomy. It's fully endoscopic transforaminal approach. Um, This is microlumbar discectomy is still the gold standard all over the world. I think there are different approaches, and now this endoscopy discectomy is improving. It's a new innovative technique, and I think people are trying all over the world. It might be future armamentarium for spinal surgery. Is it difficult? Is technically demanding? Um, why this approach we want to use this? Because it attacks the pathology directly. There are different schools of thought. People use in prone position or lateral position. Of course, you need equipments for this, like the tower, the endoscopes, the endoscopic instruments. The indication is same as microlumbar discectomy. And also we can use this in the recurrent discs as against lumbar microdiscectomy. We know when we go second time, there is a lot of scar and adhesion and how much we suffer. But here we can go again in the same place because the scarring is very minimal. Contraindications, same as very hard disc. Actually, our selection is below the age of 60 within 6 months period when the disc is soft. If the spine is deformed, you can't see the anatomy properly. Severe foraminal stenosis are the contraindications. We still do alpha S1 through this process. Initially, we thought iliac crest will come in the way, but most of the cases we are successful. Advantages is early mobilization is done under sedation and local anesthesia. Patients go home same day. It can be done in obese patients. That's another big advantage. You can very rarely in pregnant patients. It is done under local anesthesia sedation, suitable patient with medical problems, reduced risk of infection, reduced risk of instability, less subsequent scars, and you can do the same operation again in recurrent disc herniations. There is a reduced rehabilitation time and therefore can join the job early. Of course, it is demanding for the patient to cooperate with this position under sedation and local anesthesia, demanding for anesthetist. He has to communicate with the patient all the time, and surgeon has to also communicate with the patient during surgery. And of course, as usual, there is exposure to radiation during taking x-rays. History, we know Parviz Kambin, 1973, introduced the concept, and obviously all other these people, Professor Thomas Hugland from Germany, Anthony Young, Sebastian Rutten, Michael Schubert, Menno Ipremberg, and the South Korean team, Sang-ho Lee, Gan Chai, and Daniel Kim from USA popularized this technique. Coming to the anatomy, this is the foramen. We can see that it is the lower border of the pedicle above and lower upper part of the pedicle below. And you can see it is oval shaped, but the broad area is on the top. Anteriorly, posterior part of the body of the vertebra and disc, and behind the facet joint complex. These are the dimensions as we see in the anatomy, and you can see the alpha S1 is the smallest one. That's why people have difficulty in putting. You should start with L4-5 to start with. And we thought when we started L5, when we consented that if it's not possible, we'll do the standard microdiscectomy. but subsequently we found we could manage to get into L5S1 as foramen as well. Transforaminal contents like veins, arteries, and nerves, and the ligaments. But you can see the nerve here and the top portion where it should be avoided, and that's why our trajectory is here in the Cambin's triangle as we describe here. Professor Parviz Cambin described this in 1990, and that's the triangle lined by mainly the exiting nerve and the traversing the roots, where it is safe to put the needle and the endoscope in that area. This is our equipments, the tower and the endoscope, the coagulator, the forceps, and the new things that are developing we have added now is the drills which we can use. We can use the punches. Now that is becoming very useful, and especially for foraminoplasty. So we want to dilate the foramen, we can use that. There are instruments for soft tissue dissection. This is for hooks and probes for palpation. So things are improving as the technology is improving as well. So we do usually in the lateral position, and that is our theater setup. This is just a presentation, which is animation. We put patient in the position. Sometimes we put some support under the lumbar region, but nowadays we just fold the table itself so that the foramen opens more as we go from the top. That's the iliac crest site, and then we take this position. You can see the inset picture, how that angle is as we go into the Cambin's triangle through this approach. So local anesthesia, and then you put the needle. Obviously, you have to take this. It takes a little time initially to put a needle into the foramen correctly. You have to check both in AP and lateral X-rays. And when the needle is there, initially we did this dye or putting methylene blue, but nowadays we are not using anything. As you practice more, probably it's not required. But initial period, it is worthwhile doing this. When the guide wire is there, on the guide wire, you can take this after that skin incision and put your rod on the top of that. And there are various dilators and the reamers, which we use to dilate the foramen. So as you see here, there is a green rod on which the tube comes. Green tubes come, and then you get a green reamer. So reamer is to open up the bony part of the head. So it drills the superior facet, as you can see it more there. So it drills the superior facet, gives more space. So then there is a yellow reamer and there is a red reamer, which comes on the top one by one, and that dilates the size. The endoscope is usually 7 millimeter diameter, and you can see, and can put this is the endoscope, comes on the top of that, and you can see the tip of the endoscope showing the channel for instruments, 2 channels for irrigation and 1 for the light source. As you can see, sometimes the discs are so big that you may not be able to pull through that, and sometimes you have to take the endoscope out with the disc out. I will show that in the video later on. Then we landed up in taking the endoscope out. And irrigation is continuing during this period. You can adjust your speed depending upon, this is the coagulator. If it bleeds, you can use it to stop the bleeding. You can increase the irrigation so you get more clarity during operation. And so we got now newer instruments to drill the bone, like it's called drill or shrill, and probes. You got punches also we can use through this, and it's becoming more useful. So it's very straightforward. Once that is done, you just take the scope out, and usually there is nothing needs to some band-aid dressing also, it should be enough for this. So this is our position, as we say, and as we see iliac crest, and this with lining we mark. This is the line is the facet joint. When you do X-ray, we just mark that as well, and that is the line where the wire was put in. That was the line here, and you get approach to this L5 foramen on the lower side. The nerve root comes out from here. So these are the X-rays. You confirm that you are in good position. Then you put this guiding rod, guiding tube, and reamers. They are different colors: green, yellow, and red. And then you put the endoscope, and you can see the dye which was put in. You know where you are, and then through the endoscope you can put the scope. This is just to show that how the setup is. The C-arm there, and actually this is our screen, theater screen showing the anatomy, the images, but actually the main screen is on the right side where it's easy for you to look there, so that should be there. This plastic sheet which goes on the C-arm as well as here whole, so you can see everything what's happening. You can see the patient moving his leg during surgery. If you want to say move your right foot, if you are irritating the nerve root, you can see that. And also there is a bag at the bottom which collects the irrigation fluid, and it goes to the bag down there. This is just in presentation how we go in there. This is just for one example. You can see that blue greenish color, which is the methylene blue we injected. There are other drugs available, but were not available and very expensive. So we found methylene blue. We stopped using that also later on. But I just move forward now into this because we got short of time. So when you go into the disc space, so the disc were big, you cannot through the endoscope, then you have to take the whole endoscope, put the sheath there, and then you go back again. So this is the post-operative scar. This is very small. This patient had previous surgery and recurrent surgery with things. So life becomes very easy, and it's good indication in recurrent surgeries as well. So another indication I find personally very good is this far lateral disc prolapse, where the disc is just sitting there and you just pull it out, which becomes very difficult through microdiscectomy approach. The philosophy behind it, we are directly attacking the pathology, not taking the bone out or dissecting the muscles. Of course, training and practice is required. You need equipments. Patient selection is also important. As I said, soft discs are better. Initially, you should take the acute cases. It's demanding for the surgeon, anesthetist, and patient. Obviously, we talk about conservative period of all discs, but the life has become so hectic. Nobody wants to wait for few months, even before, with conservative treatment, and then go for surgery later on for another few months to take rest. But those people who are busy and the time is very precious, probably, and if they are in pain, and they can go ahead with this with minimally invasive surgery. Position can be prone and lateral. We can do L4-5 easily. There is difficulty at L5-S1, but we have overcome that with practice. The disc can migrate up and down. Then obviously you have to study that later on. Recurrent disc herniation, we can use this technique. Foraminoplasty, extended foraminoplasties also can be used to improve the diameter of the foramen. There are future developments: recurrent discectomies, foraminoplasty, stenosis, infection, where you can get a sample for culture, you can biopsy of the lesion, and maybe future role in fusion surgery. This may emerge as gold standard in future. Technically, it's challenging. Of course, somebody has to do at least 50 operations to get adequately trained. Attending courses, personal training, and working with the experienced surgeon helps. Once you start continually doing regularly procedure. Otherwise, we'll lose the gain. You don't gain more. So you have to do it regularly. Thank you for your kind listening to this talk. Thank you. Thank you.
Kulkarni, thank you so much for this excellent presentation. In my daily practice, I'm not using endoscope, but I believe that the future is minimally invasive surgery. And some of our colleagues have started endoscopic surgery, but the main problem that we have solved, the Camben triangle. Yes, we know the anatomy well, but the anatomy is not as drawn in the figures there. Did you have any problem about the Camben triangle there? Because if the patient is awake, yeah, you may ask the patient when you're putting your guide there at the beginning of the surgery. If the patient is awake, yes, you ask the patient, do you have any pain? Did you have any problem about the Camben triangle there?
Correct. As we said, we don't see the Cambine's triangle when we are doing.
Yeah,
We're just putting the needle blindly
yeah,
as per that triangle angulation, and we direct the needle into that space.
yeah,
Obviously, when you put the scope in, then you probably realize where you are, or the patient tells you if the patient is awake, is we are touching the exiting nerve root. Then you come to know that you are touching the patient. The patient immediately moves his legs, and then you
yeah,
know we are in right. You can change the direction again. But obviously, we are not going to see any triangle there while putting the needle.
yeah.
That's true. That's true.
So, if the patient is not awake, okay, how do you solve it? The main problem is that, yes, if the patient is awake, you see, you put your needle. Do you have pain? Do you have any numbness in your leg? Yeah, the patient says that. But in some conditions, if the patient has general anesthesia, under general anesthesia, do you use neuromonitoring or
No, we don't do general anesthesia. We do it under local only, local and
okay,
sedation. But we have find in some cases when they are in deep sedation also. See, once you used to do, now people have, my colleague has done 1,000 cases. So once you know you are doing so many cases, then you know where you are. So you don't
yeah,
need all those things. Even if he said no, we can do under GL, so there is no problem if some problem is there. So it's just a practice, really, nothing more than that. I think it with practice the issue gets resolved.
Kulkarni, thank you. Any questions from the
Yeah, Dr.
yeah,
Can I ask?
yeah, please.
Yeah, excellent presentation, Dr. Kulkarni.
Thank you.
So, what is the end point of your disc removal? When you think like now the enough disc is removed and now root is decompressed.
Yeah, you can see the pulsations of the nerve roots improve definitely. And when your disc is removed, the whole idea is to decompress the nerve root. We are not going to take the whole disc out. So once that is done, your job is done. Like in microdiscectomy, also people say, you just take the disc out, don't poke down into the posterior longitudinal ligament, don't make the hole bigger because that increases the risk of recurrence of the discs there. But here uh, we just take the disc out, make the nerve free, and that's job done. So there is no particularly we can't go on digging the whole disc out. We don't want to do that. So whole idea is to decompress the nerve root.